So do you want to put up the welcome slide?
Yes, we can.
Should I stop sharing?
Can you please?
Okay. Welcome, Kelly.
Good morning. How are you guys doing?
Good, thank you.
Morning. You're a moderator, I believe.
Yes,
Okay, good. Your audio sounds good. And you're gonna be moderating from the area you are.
correct.
Okay, good. Okay, so I think you're good because you're gonna be with Restretti, right? Correct.
Yes.
Okay, wonderful. All right. Did you want me to pull it up, Dr. Shar, for the 2 minutes, the welcome sign?
So you can do that.
Okay.
So who is kicking off? Is it Dick or is it
Yeah.
Dr. Johnson? Okay, good. So we'll Dick, Richard. So I'm starting the webinar now.
Okay.
Ready for me? There you go. Welcome, everyone. My name is Richard Verstraete. I will be one of your moderators this morning for the start of this program. A little bit about myself. I am a nurse coordinator with the Bloodless Medicine and Surgery program at Georgetown University Hospital. This is my going into my or ending my 14th year as the nurse coordinator for the program. I also am the coordinator for the patient blood management program, as well as our inpatient and outpatient immune management program. I want to welcome you all to this conference here. I'm very happy to be here with my co-moderator, Dr. Kelly Johnson-Arbor, who's a good friend of mine, and we've collaborated on a lot of publications together. So Kelly, welcome.
Thanks, Dick, and good morning or good afternoon, everyone. Hi, I'm Kelly Johnson-Arbor. I also work at MedStar Georgetown University Hospital along with Dick Verstraete. I'm a physician and my role is medical director of hyperbaric medicine. And we use hyperbaric medicine a lot here and collaborate very closely with the Bloodless Medicine Service to treat anemic patients who are unable to receive transfusion. So I'm happy that everyone is here this morning. Today is the third and the last day of the BMSS 2024 annual meeting. Of course, the theme is Medical Informatics, Advancing Bloodless Medicine. Today, we will have 2 scientific sessions as well as the annual general meeting of the Society. And before we start, I will hand it back over to Dick to remind us of some housekeeping rules.
Yes, just some housekeeping rules. All questions should be placed in the Q&A. Minimize your charts during the talks so as not to disrupt or distract other attendees and the speakers. The program is being streamed live on the BMSS YouTube channel in case anyone has difficulty with Zoom. See your YouTube channel link in the chat or type Bloodless Medicine and Surgery Society in YouTube search. And if there's any other housekeeping rules and information considered relevant, well, I think that's about it. So Kelly, it's back to you again.
Perfect. Thanks, Dick. All right. So the Society of the Advancement of Patient Blood Management, or SABM, is an organizational affiliate of the Bloodless Medicine and Surgical Society. And today, our first scientific session is on adverse outcomes of blood transfusion, making the case for transfusion avoidance in modern medical practice. And our first speaker is Dr. Mark Friedman. So Dr. Friedman is a clinical associate professor of pathology and the medical director of the transfusion service at NYU Langone Hospital, Long Island, NYU Grossman Long Island School of Medicine, and the Department of Pathology in Mineola, New York, in the USA. Dr. Friedman is an associate professor of pathology and the director of transfusion and therapeutic apheresis services at NYU Langone Health and Grossman Long Island School of Medicine in the US. He has over 25 years of experience in the field of blood banking and transfusion medicine, and he's board certified by the American Board of Pathology. He holds memberships in multiple organizations, including SABM, the AABB, and the Blood Bank Association of New York State, and he has extensively published on topics covering patient blood management, including his contributions to the PBM column for the AABB website. And his research interests include insights into appropriate blood utilization and PBM education. And I'm super excited to hear his talk this morning. So take it away.
Thank you for that wonderful introduction. Let me just share my slides here. All right, can everybody see that? Yes, okay, good.
Yes.
All right, so it's wonderful to be invited to talk at this session. As noted, my topic here is adverse outcomes of blood transfusions and making the case for transfusion avoidance in modern medical practice. Now, so I have no disclosures for this presentation. And the learning objectives are to recognize historical transfusion risks, such as hepatitis and HIV in the current context, to explain the transition of transfusion risk reduction from transmissible diseases to non-transmissible disease risks, and to analyze the case for transfusion avoidance and transfusion risk reduction. So I put this champion athlete up, tennis player, who some of you perhaps, or maybe many of you recognize is the late great Arthur Ashe, who in fact has a tennis stadium here in New York named in his honor, where they play the US Open every year. However, what fewer people might remember about him is that he became an HIV/AIDS activist before dying from AIDS, unfortunately, in 1993. And the way he acquired HIV, of course, was through blood transfusion. So I bring him up here in memoriam, in part because our paths sort of intersected, because much later on, I actually became the blood bank director in that New York City hospital where he got that unfortunate blood transfusion. So it just serves as memory of the, that era of blood transfusions during the HIV epidemic. Stepping back a moment into post-transfusion hepatitis, the risk of post-transfusion hepatitis dropped from the 1940s with the introduction of hepatitis B surface antigen screening in the late 1960s to early 1970s. And it was originally called the Australia antigen because it was the agent was identified apparently in Australian Aborigines. But the post-transfusion hepatitis risk, despite hepatitis B testing, was still very high, perhaps as high as 10% in the 1960s to post-1970s. So it was still very high, and that was because of non-A, non-B hepatitis was really largely the agent that was being transmitted, and later, of course, identified and then around 1990 as hepatitis C. What the U.S. did around that time to try to make the blood supply safer, of course, was to call to action a move to voluntary non-paid blood donor supply in the U.S. And then later, after HIV, we tried to identify high-risk donors, and so we started testing liver enzymes, ALT, and also introduced hepatitis B core antibody testing. That somewhat reduced the risk of non-A, non-B post-transfusion hepatitis from about 1 in 200 to 1 in 400. And then, of course, as I mentioned, in the 1990s, we identified hepatitis C as the agent and began testing for that. Nevertheless, now if we look at the current context, there are some who want to go back to paid blood donations, particularly for platelets. And when you look at this particular paper, these authors actually were arguing against that move. Yes, we have better methods to screen and test donors. We also have newer technologies such as pathogen reduction technologies, which can inactivate these viruses. But then they were questioning whether this would erode the altruistic donor base. When it came to post-transfusion HIV, which of course was epidemic that started in the 1980s, but the first documented case of post-transfusion HIV in the US occurred in 1982. And then after we identified the agent as a retrovirus in the around 1984, then we began antibody screening in 1985. And also at that time, that's when we began to defer high-risk donors. Men who had sex with other men were considered to be high risk and were basically deferred or banned from donating until most recently now, when we've actually put more individual risk factors to evaluate donors. So then HIV NAT testing was added in the 2000s. In between the antibody testing and the NAT testing, and briefly in the 1990s, we were doing HIV P24 antigen testing, which started in 1996 here in the US. And that, of course, was the goal was to reduce the so-called window period, which is the period between acquisition of the infection and ability to detect the virus. So with antibody testing, that window period was about 3 months. When we went to P24 antigen, we greatly reduced that. And now with the latest in NAT testing, we have about a 10-day window period. And of course, today we test not only for HIV-1, we also test for HIV-2, and also the outlier HIV-1 group O HIV. So in today's context, post-transfusion HIV, of course, like hepatitis C, is extremely low, in the order of 1 to 1.5 to 2 million. So it's extremely rare. Nevertheless, we can see that cases occurred in the US even as late as 2008. So, we still have to be cognizant of HIV in the blood. So you can see that with our current screening and testing, HIV, hepatitis B, hepatitis C, extremely rare to get that. But they should not be forgotten, in part because nowadays we have these very highly active antiretroviral medications that people take for post-exposure prophylaxis and even pre-exposure prophylaxis. And these can render even infected people negative, even on NAT tests. Though it still can be, the virus sexually cannot be transmitted for people who take these medications, but through blood, it can still be transmitted. So we really have to be cognizant of this. And today, the FDA has recommended that donors who take these medications be deferred for 3 months. But what is the cost that we how much are we willing to spend in order to make the blood supply safe? And if we look at just one agent, babesiosis, which of course is a parasite that, like malaria, infects red blood cells, but is endemic here in the US and parts of the US, particularly in the Northeast, where I'm located, and also in parts of the Midwest. So you can see, normally when we look at cost expenditures, in terms of healthcare interventions, we measure them in something called QALYs, or quality adjusted life years. And its benchmark is said that if you spend about $1 million per QALY, that's basically considered to be a worthwhile intervention. But once you exceed that expenditure, then the healthcare dollars are getting very expensive. So if we look at just testing for babesiosis, if we just screen through the donor history here at the top, you can see you're spending about $160,000 to make the blood supply safe per QALY. If we now add targeted antibody PCR, that is, if we're just doing it in endemic areas of the US, we're spending over $700,000. And now if we do universal antibody, meaning that all donors are being tested by a ELISA antibody, we're spending over about $760,000. And then when we go to universal antibody and PCR testing, it gets upwards of almost $9 million. So it gets very expensive. So you can see we're spending a lot of money to make the blood supply safe. Now, if we move beyond transmitted infections, we can see that we have a number of other risks that we have to be cognizant of. ABO, hemolytic transfusion reactions, which usually occurs because of patient misidentification. The usual mechanism is that it's what we call a WIBIT, or warm blood in tube. And so what happens is the sample gets labeled with the intended recipient, but for whatever reason, the blood is collected from a different patient. And then when that sample is sent to the blood bank, they type the patient and that sample and cross-match to that sample. The blood gets transfused back to the intended recipient now, but clearly it was cross-matched to a different patient, and it can end up in a hemolytic reaction, which can be unfortunately fatal. Transfusion-associated circulatory overload, or what we call TACO, volume overload essentially, transfusion-related acute lung injury, trolley, bacterial contamination of platelets, hypersensitivity anaphylactic reactions, alloimmunization in terms of HLA antibodies, and delayed hemolytic transfusion reactions, transfusion-associated graft versus host disease in immunocompromised patients, and iron overload transfusional hemochromatosis. And finally, more esoteric reactions such as transfusion-related immunomodulation, TRIM, and prothrombotic effects. So looking at ABO hemolytic reactions, you can see that this should be a never event. I mean, we know what the donor blood type is, and we certainly know what the patient blood type is, but somehow, as I mentioned, there is a mix-up, a clerical error, and unfortunately, it leads to these hemolytic reactions. And in this case, it was reported that a woman in Texas here in the US was given the wrong blood, and she unfortunately died of that consequence. So how do we deal with this? Well, if you look at this chart here, what many transfusion services have adopted is nowadays is we will, of course, we always do a history check, but if we don't have prior type and screen on the sample, prior history, what we do is we ask for a second sample to confirm the ABO type and make sure that it matches up and that we have the right sample from the right patient. So we've identified the patient correctly. Nevertheless, I have to say that in my experience, I've seen clinical teams that they don't really understand the purpose of this, and they think that we're just trying to make things more difficult for them. And so I've seen situations where, for example, they'll collect 2 samples at one time, put one in the pocket, then give the first sample, and when we ask for the second sample, they'll pull that second sample out. So I mean, we try to put the safety measures in place, but yes, there's always a way to bypass that. Some hospitals, what they'll do is they'll actually have special tubes for the second sample that can only come from the blood bank, so that they cannot just collect the 2 samples at one time. Sorry. All right, moving on to TACO, or transfusion-associated circulatory overload. And you can see that, the ABB put out this bulletin in 2015, and they updated it in 2023. And you can see that, unfortunately, TACO remains a leading cause of transfusion-related morbidity and mortality. And you can see that TACO contributes, may have contributed to over 21% of transfusion-related deaths. And although TACO symptoms have been recognized for more than half a century, we still incompletely understand all of the mechanisms. It seems fairly straightforward, but it's a little more complicated, as we'll see. So certainly we try to identify at-risk patients, patients who are older or female sex, patients who have underlying renal failure or pre-existing cardiac dysfunction or chronic pulmonary disease. There are also practice-specific practices that put the patients at risk. For example, giving more than 1 unit of blood. So we always say why give 2 when one will do in terms of red cells. So certainly if they're doubling up on their red cell transfusions, that can contribute to a TACO. giving faster rates of transfusion. Plasma transfusions tend to be greater risk than RBCs because they are given in multiple units in order to get an appropriate dose. And so these are things that do contribute to the risk of TACO. And there are certain biomarkers that we can measure, like the BNP, for example, the brain natriuretic peptide, as an indicator of TACO. How does TACO occur? Well, there are physical forces like the Starling forces, which, when the pressures get high, they'll push fluid from the pulmonary vasculature into the airspace. Pulmonary vasoconstriction, the blood vessels tend to tighten up, and that again can contribute to increasing pressure and fluid leaking from the pulmonary capillary vessels into the air spaces, and endothelial damage, so you get leaky vessels. But these aren't the only contributors. We do know that there is a component of inflammation involved, and we used to say that TACO really was, fever was not really a component of TACO, but today we recognize that even up to about a third of cases can, have fever. So this has been something that's been labeled as a hot TACO in the literature. Transfusion-related acute lung injury is another differential when we're looking at transfusion-related pulmonary edema. And this is more, yes, there can be an inflammatory component, as I mentioned, to TACO, but this, does always has an inflammatory component to it. And it tends to occur in very sick patients, particularly those in the ICU. And the underlying illness leads to neutrophil priming, which then attaches to the endothelium, these primed white blood cells. And then when we, in the second hit, when we infuse either HLA antibodies or these bioactive lipids that build up in stored products, that leads to the second hit and activates these primed white blood cells and leads to the leaky capillaries, pulmonary capillaries, and hence the fluid, the pulmonary edema that occurs. So here the ABB put out a bulletin back in 2014 about mitigating TRALI and preventing TRALI, trying to reduce the risk of TRALI. And one of the things that was recognized is that, one of the big drivers of HLA antibodies that's a risk for that second hit in TRALI is pregnancy. So if we can simply eliminate particularly plasma products from female donors, or at least get products from females who are tested for HLA antibodies, that would make the blood supply safer. So we sort of have this male, predominant plasma to try to make the blood supply safer from TRALI. However, TRALI is still incompletely understood, and you can see that it was although cases occurred prior to 1983, the term TRALI was coined by Popovsky and others in 1983. And then the definition was updated around 2004 by the Canadian Consensus Conference, which sort of put the definition as this pulmonary edema that occurs within 6 hours of transfusion that's related to, not related to acute, other acute lung injury factors, and certainly not related to heart failure. But nevertheless, additional updates to the definition came out in 2005 and again in 2009 and 2018. And most recently in 2019, they sort of then divided TRALI into type 1, where there's no other underlying acute lung injury, or type 2, when the patient does have risk factors for ARDS or mild ARDS. But the current event is clearly not related to those underlying risk factors or pre-existing mild ARDS. And more than just the classic mechanism that we understand about the two-hit hypothesis, the priming of the white blood cells as illustrated, and the activation, nowadays we're looking at additional causes for TRALI, or mechanisms of TRALI, including macrophage secretion of osteopoietin and these so-called neutrophil extracellular traps that can occur as another mechanism. So trolley is certainly much more complicated. And as they do further investigation and come up with different mechanisms that might lead to trolley, they're trying to come up with different ways that we can potentially either avoid or treat trolley. Bacterial contamination of platelets, has long been problematic, simply because we store platelets at room temperature, and no matter how much we try to sterilize and clean the skin when we collect these blood products, there's always going to be some bacteria that gets into the blood product, and of course, since it's sitting at room temperature, that can promote the overgrowth of bacteria in these products. And we know that, unfortunately, bacterial contamination has been one of the more common causes of transfusion-related deaths, at least globally and in the U.S. But there still exists no standardized test to detect all bacteria in platelet units, and regardless of the method, bacterial screening of platelets is unlikely to detect all pathogens. So, we've introduced a lot of mechanisms to try to reduce the risk of bacterial contamination of platelets and consequently septic reactions. One of these mechanisms that we put in place is the so-called sample diversion pouch, which is over here. Basically what we do, we recognize that when you put the needle into the donor arm, not only do you get the blood flowing out, but you get a big piece of skin that gets into that needle. And that skin, if it gets into the primary bag, it has a lot of a lot of bacteria that's associated with it, and that can promote overgrowth of the bacteria in the product. So what we tend to do nowadays in the donor collection sites is we actually divert a small amount of the initial collection to get rid of that skin plug, and we can use that for transmissible disease testing, for example. And then in midstream, we can switch the collection into the main bag, so we avoid that skin plug and reduce the amount of bacteria that gets into the product, and that should mitigate or at least reduce some of that bacterial overgrowth and consequently septic reactions that we see with platelets. So in 2019, and again updated in 2020, the FDA, in recognition of the risk of bacterial septic reactions, came out with this guidance to promote reducing the risk of bacterial septic reactions, bacterial contamination of platelets. And this guidance basically listed various steps that we can use in order to test platelets and make them safer from bacteria. One of the more common strategies that many blood centers here in the US use is so-called large volume delayed sampling platelets. And what they basically do is they wait 48 hours, let any bacteria grow, and then they will culture it to see if they can detect any excess bacteria before releasing that product. One of the downsides of that, though, is because they are taking larger samples from that platelet unit, we might get a little bit less platelets in the actual product. So what we call low yield platelets. But of course, when we look at the platelet requirements here for concentration or yield in the US, it's higher than in European and in Canadian nations in any case. So even if we do get a little bit lower platelet yield, we're still, we still have an acceptable product for transfusion. Another technology that we now have is so-called pathogen reduction, which the FDA has recognized as promoting safer products against bacterial contamination. And when we look at this technology, essentially what we're doing is we're adding a photoactivating chemical, a seralin agent like amotacillin, and then what this does is it cross-links, we then subject it to UVA light, and what this does is it cross-links DNA and RNA, and it knocks out all kinds of pathogens, bacteria, viral pathogens, including HIV, hepatitis C, hepatitis B, and even white blood cells, rendering the product safe from graft versus host disease. Transfusion-related immunomodulation. So this is a more esoteric type of risk that was first recognized in the early 1970s by Peltz and Terasaki and others. And actually, it was looked upon as a favorable consequence of transfusion. So what they would do is in their kidney transplants patients, they recognized that the patients who actually got blood transfusions and got their renal transplants, the renal allografts survived longer, because essentially what was happening is that the active white blood cells in these products, back then, of course, it wasn't, they weren't universally leuker reducing like we do nowadays. So you have lots of white blood cells in these donor products. So these white blood cells in the donor products would essentially immunosuppress or downregulate the recipient's immune system, and that would prevent allograft rejection and longer survival of the kidney allograft. So they would actually intentionally transfuse the patients who were undergoing kidney transplants. Of course, then, you know, in the 1980s, there was the HIV epidemic, so they stopped doing this. And of course, they developed better immunosuppressive agents like cyclosporine. So nowadays, we recognize TRIM as a negative outcome of transfusion. And there are various mechanisms that have been promoted to explain why TRIM occurs, including not only the active white blood cells in the donor product, which we largely remove nowadays through universal leuker reduction, but also formation of extracellular vesicles and free hemoglobin and iron that occurs in these stored products. And in platelets, free CD40 ligand is another promoter of TRIM. So suffice it to say that there are multiple mechanisms that can lead to this transient immunosuppression in those who receive blood products. And we recognize that this has a negative outcome because it can lead to organ dysfunction, nosocomial infections, and even progression of malignancies. We know that, for example, in perioperative patients, it certainly does increase the risk of infections in that group of patients. Prothrombotic effects. So we see here from this study in patients who were undergoing total joint arthroplasty, and as they received more blood transfusions, their risk for venous thromboembolic events increased. So we know that transfusion of these products, they do have prothrombotic effects. So as a result of all of these risks, the World Health Organization not long ago in October 2021 put out this brief, this policy brief on the urgent need to implement patient blood management. And I know that this was a slide that was shown in an earlier presentation, but just to go over it again, the World Health Organization largely were looking at this data from the largest patient blood management program in the world, from Western Australia. And this particular study was looking at over 600,000 patients from that region. And what they found was that there was a correlation that when they reduced the risk of red cell transfusions here by over 40%, plasma by nearly 50%, and platelets by nearly 30%, they had a nearly 30% reduction in mortality, over 20% reduction in infections, over 30% reduction in thrombotic events, including acute myocardial infarctions and stroke, and the length of hospital stay decreased by 15%. And there were the key program indicators were that they reduced preoperative anemia from 21 to 14%. They decreased the pre-transfusion hemoglobins from nearly 8 grams per DL to 7.3 grams per DL, and they nearly doubled the rate of single unit transfusions. So we know that the transfusions do lead to higher risks and morbidity and mortality in patients. And as a result of this, of course, there was a whole lot of healthcare dollar savings. You can see they saved in activity-based costs upwards of 100 million Australian dollars. So that's all I have, and this is my references. And I thank you again for inviting me to speak.
Dick, if you're talking, I believe you're muted.
Sorry about that. Thank you, Dr. Friedman, for your wonderful presentation. It was very interesting. I'd like to introduce our next speaker, Sarah Walpole. Sarah is a PBM educator and implementation specialist. She is the host of a podcast called Let's Talk Patient Blood Management. She's a SAVA member, board member. She's a surgical nurse at ProMedica in Defiance, Ohio. Sarah is highly experienced in developing patient blood management in healthcare system. She remains active in the Society for the Advancement of Patient Blood Management and is utilized as an implementation specialist to mentor healthcare organizations to establish PBM programs. Sarah serves on various SAVA committees and as a board of directors. Sarah also participates in PBM Standards Committee with the AABB. Her nursing background is in gastroenterology, OR, and administrative nursing. She is fueled by a passion for bringing awareness to PBM. She enjoys patient advocacy for patient blood management and bloodless care populations. In 2022, Sarah co-developed the Let's Talk Patient Blood Management podcast to bring awareness and education of PBM. Sarah loves traveling, meeting new people, and hearing their stories. She is dedicated to lifelong learning and teaching. Sarah, welcome.
Thank you. Thank you, everyone. Good day. Today, I'm going to talk to you on the topic of the important role of podcasts and social media in contemporary bloodless medicine and PBM education, and how we can engage and educate in a digital age. And my endeavor here is to, if you have not participated in social media education, to begin to create some content. And if you are, maybe to expand how often that you are on the social media platforms. So a little bit of history of media. Media through writing and the passing down of knowledge and information dates back all the way to 3400 BCE with the Sumerian cuneiform tablets and the Egyptian hieroglyphics. Johannes Gutenberg revolutionized media when he invented the printing press in 1440. This was the first opportunity to have mass production of printed materials, and it opened up the opportunity to share news and information with many people at one time. In 1900, Tesla registered for the first patent for a radio, and suddenly people were gathered around radios to hear the latest news, to attend church services, and as a form of entertainment for their families. In 1920, the first universities began to offer courses via radio. And in the 1930s, the governments were using film industry and films to sway national allegiances. And then, of course, with the 21st century, right around the 2000 era, social media came onto the scene. And social media was a shift in that instead of the information being dispensed by a relatively few, maybe members of government or media outlets, now everyone had the ability to share knowledge and information. And now we can discuss the positive impacts and and the not so positive impacts of social media, because they're definitely there. But it is a fact that social media is here to stay. And it's a very, very powerful to sway public opinion. And so we do need experts in bloodless medicine to be influential voices in the digital space. And we need medical leaders and experts to promote accurate bloodless education and to address myths that are out there. So platforms like Twitter, YouTube, LinkedIn can really amplify PBM and bloodless medicine. And I use this infographic as a sample. This infographic on social media can do more in just a couple minutes to educate a patient regarding the risks of transfusion and the symptoms that they should look for to see if they're having a reaction. This is probably better education that a patient gets bedside with a clinician when he's trying to consent them for a blood product. By sharing case studies, infographics, visual stories, it can help simplify complex topics and it can reach a broad audience. Conversations between professionals and the public enhance our credibility and foster trust with the public, which is something that's kind of on the decline. There's a digital shift in even medical education. So podcasts and social media is very powerful for delivering crucial bloodless medicine and PBM education. Podcast listening has been preferred in reading and reported in satisfaction ratings. They would rather listen to a podcast than to read a textbook. Social media also supports patient empowerment by explaining and giving knowledge to the public and patients, and it places them in a position where they can take control of their healthcare needs, and they're more likely to advocate for bloodless intervention. So why should you become involved? There's actually many reasons why you should become involved. Society is beginning to lose trust in the medical model. And the reason is they feel discontent over maybe the time they get to spend with their clinician, or they feel that their clinician is distracted. Maybe he has to be charting at the same time that he's talking to them. And so they feel like they're truly not heard. But when you engage with them on social media, it earns back some of that trust. When you look at a camera, it feels to them like you are looking them in the eye and you're focused on them and you're drawing them into a one-on-one conversation. Usually when you record a social media reel or you participate in a podcast, you're in a more relaxed setting where there's less demands on and constrictions on your time. And they can feel that difference. And just like Gutenberg's printing press, the wonderful thing about social media is you can be having these one-on-one conversations with people, multitudes at a time. You can have 1,000 conversations all at once happening simultaneously. I'm going to show you some examples of some medical and scientific social media physicians that are using social media platforms to engage an audience and to teach. And you can see here by their subscribers, how many subscribers that they have. They're reaching far more people than they can by just sitting in their office on one-to-one conversations. I'm going to show you this reel that was made by this first clinician, Dr. Karan Rajan. And I think you will find that he drives home a very important part why social media has great impact for public education. And also, it's very entertaining.
I recently posted a video about a woman who had something that looked like a pimple on her face. And it turned out to be a basal cell carcinoma, a type of skin cancer, one of the most common types of skin cancer related to sun exposure. And I made a video about how these can often look like just pimples. So if you have a pimple that's just not going away and it's there for several weeks, probably get it checked out. Because, it could be something like a skin cancer, which is easily treatable in the early stages. And I got dozens and dozens of messages after that video saying, I just got checked out and my dermatologist has picked up this cancer, this skin cancer. And for me, that was, the light bulb moment. That impact you can have on 12 people, on one person even, is way more important than getting 1 million views or 10 million views. Who cares? What's the price of saving someone's life? For me, that is the underrated metric that I care about now. Every video I make, I don't really care about the views at all. Can it have an impact on someone's life? And for me, that keeps me going now. No matter even if I get 10 views.
So his last, I know it was clipped off. He says, no matter if I get 10 views, right? I don't care. If I've impacted somebody's life, if I've been able to save someone's life, that brings me fulfillment. And now I think we would all agree that we believe that bloodless medicine is a life-saving intervention. And so, if you look on this list of very wonderful clinicians, we see that there's a gap. We see that there is no bloodless medicine personality that is very heavily, in social media. So who will fill that gap? It remains to be seen, but I just wanted to let you know that the spot is open. So in the digital shift in medical education, one survey found that 88% of medical students reported listening to a medical podcast at least once a month. And it showed that the medical education through podcasts to be equivalent to traditional teaching methods. And the medical residents who participated in learning through a podcast showed improvement in their documentation skills as medical students. So it can be very powerful. Why are podcasts such great educational tools? Because they allow for listening on the go, making them ideal for very busy health professionals. Long-form content enables in-depth discussions on bloodless medicine, including patient stories, and then the expert insights from that story. They're excellent platforms for continuous professional development and public education. Physicians reported that they felt increased efficiency because podcasts allowed them to multitask. They reported using medical podcasts as for both education and for entertainment. And they perceived that the medical podcasts helped them to stay up to date and current with new literature coming out. Medical podcast education, they reported, had changed and impacted their decisions in clinical practice. So I wanted to share with you some motivating medical leaders among the bloodless care population and insight and PBM insight, and what impact we are having, but there is a lot of space for more. So this first video, and I will share it, was from Johns Hopkins University. And you can see it's a well-made video, and it has received 42,000 views. And I know that I'm preaching to the choir and you'll know this information, but I want you to see how in a very short 2-minute video, you can be offering alternatives in various spaces to the public.
Every year in the U.S., patients receive 21 million blood transfusions. What if there was a better solution with significantly improved outcomes?
So nearly every surgical procedure involves some degree of blood loss. And traditionally, we give patients blood from the blood bank. However, another option exists, which is called bloodless medicine and surgery, where we use alternatives to transfusion.
Techniques performed before, during, and after surgery result in faster recovery, fewer infections, and quicker discharge. Bloodless medicine eliminates the need for blood transfusion, thus avoiding the dangers of allergic reaction, contamination, and the possibility of receiving the wrong blood type. Before surgery, medication and nutritional supplements increase hemoglobin levels, which help your body handle blood loss during surgery. A process called hemodilution temporarily replaces a portion of the patient's blood with fluids, lessening the impact of blood loss during surgery. Tools and techniques used during surgery include anesthesia processes to safely lower blood pressure, harmonic scalpels clot the blood while cutting the tissue, cell salvage machines collect lost blood, wash it, and return it to the patient. Hemoglobin monitors reduce the need to collect blood samples to be sent to the lab. After surgery, medications and techniques can minimize bleeding and improve oxygen in the blood. Often after surgery, blood must be drawn to run follow-up testing in the lab. Microsampling requires 1/10 the amount of blood traditionally drawn, reducing the amount of blood patients lose by almost 90%. At Johns Hopkins, our team of highly trained experts have been providing patients alternatives and peace of mind for years.
I think you can see that that was a very well put together 2-minute video that gives patients and the public an alternative option. And just the visualization of the microsampling really brought home and showed in pictures the message. We also had Dr. Usoro visit our podcast, and the podcast was celebrating the science and the history of bloodless medicine. And you'll see that it received well over 800 views on our YouTube channel, and it performed very well on our audio platforms as well. And it has actually been one of our highest watched and listened to downloaded videos. It's a 30-minute video, so I won't share it with you here today. I also wanted to share this video of Sherry Ozawa, because Sherry, in a very short reel, shared her own personal experience, and that is really beneficial to the public.
I'm a mom of 4 kids. About 10 years ago, I had to have surgery myself. Did my preoperative testing to find out that I had a hemoglobin of 7. It was ironic, right? Because I've been doing something related to patient blood management and blood health for almost 30 years. I myself had heavy menstrual bleeding, but didn't know it was heavy because I didn't have anything really to compare it to. I feel like there's days and years even I missed out on things that I could have with my kids, with my own brain, with my own emotional health, mental health. And it was astonishing to get that intravenous iron. I absolutely physically and psychologically felt better immediately. You know, I don't sell intravenous iron for a living. It was what I needed. I was iron deficient, tremendously iron deficient. And I spent decades counseling patients about exactly those reasons. And yet, as a woman, completely overlooked it in myself for years.
You can see that that has been shown well over 22,000 views and downloads. And Dr. Shander, with one of his trailers of our podcast, over 6,000 views. So we can have impact in the digital space. So I want to share with you some practical tips if I've convinced you to kind of engage in social media. Sorry, let me try to go backwards here if I can figure out how to go backwards. Almost done. So. Okay, so practical tips. It's not named. Okay. Practical tips for getting started. You can start by creating a profile on key platforms like LinkedIn, Twitter, whatever social media platforms you're most familiar with. And then you can create your own educational content. And really, the shorter, the better. If you can teach one point in 1 minute, you'll have much more success than long videos. You can create your own educational content, or you can help expand the content that you find online. Someone's made a very good piece of content, make sure to forward that on your social media platforms. It reaches a broader audience. And think about starting a bloodless medicine podcast or offering to be interviewed on bloodless related podcasts. So let's say your specialty is anesthesia. Offer yourself up, reach out to that podcast creator and say, hey, I work in the anesthesia field and I practice patient blood management. I'd like to talk about the benefits of patient blood management and bloodless medicine. So wherever you can get an in, women's health, whatever, reach out to those content creators and say, I have new research. I would like to share it with you and how the benefits of bloodless medicine. So it doesn't have to be a bloodless medicine podcast or a PBM podcast. But if you do have something new and interesting going on, if you have a story to tell, podcast content creators are always looking for engaging stories. There are charlatans out there on social media, right? We already discussed that there's good and there's bad advice, and bad advice can spread quickly and it can cause harm to outcomes. So I wanted to give a cautionary word of advice that make sure that if you're going to forward on information on bloodless medicine or patient blood management, that it is backed by research and that it peer-reviewed studies and verified by verified medical experts really makes our trust value package worth it out on the digital space. So we don't want to be causing harm. We want to be giving accurate and reliable information. I just want to say thank you for all of the clinicians and the experts who have taken time in our first 2 years of podcasting to come in, tell their stories, tell their expertise, tell the world why it's important. We couldn't have a podcast without people volunteering and stepping up and spending time with us. And just would like to say thank you very much. And if you ever want to reach out to us for more direction, we would be more than happy to get you started or to help you out in your social media efforts when it comes to bloodless medicine. Thank you.
Thank you, Sarah. That was absolutely amazing. I learned so much. And you guys, if you have any questions, just put them in the Q&A. We should have some time at the very end of this session to go over any questions or discussions that you have about these excellent talks this morning. So in the interest of time, we will move on to our final speaker, Dr. Linda Shore-Lesserson, who will provide our keynote address today. Dr. Lesserson's title of her talk is How Does Avoiding Perioperative Transfusion Improve Clinical Outcomes in Cardiac Surgery? So Dr. Linda Shore-Lesserson is the president of SABM. She's also a professor of anesthesiology and the director of cardiothoracic anesthesiology at the Zucker School of Medicine at Hofstra North Shore University Hospital in Hempstead, New York, in the U.S. Dr. Shore-Lesserson is, again, professor of anesthesiology at the Zucker School of Medicine. She received her medical degree from the University of Pennsylvania, and she's a diplomat of the American Board of Anesthesiology and of the National Board of Echocardiography. She's a clinical and academic cardiac anesthesiologist who is the past president of the Society of Cardiovascular Anesthesiologists, and she currently serves on the board of directors of the National Board of Echocardiography. As an educator, Dr. Shore-Lesserson has been program chair for numerous national meetings, and she's currently the general chair of the New York Society of Anesthesiologists Postgraduate Anesthesiology Annual Meeting. She is the third vice chair for the ASA Annual Meeting Oversight Committee. In the cardiac community, Dr. Shore-Lesserson is a fellow of the American Heart Association, and she assumed the role of the chair of Surgery and Anesthesia Council of the AHA in the fall of 2023. Her other positions include being the anesthesiology lead working with the Society of Thoracic Surgeons and the American Society of Extracorporeal Technology on an interdisciplinary project called Best Practices in Perfusion Management. As past chair of the Committee on Patient Blood Management for the American Society of Anesthesiologists, she stays active in that medical specialty, and she now serves as president of SABM. Her research interests include the field of hemostasis and thrombosis as it relates to cardiovascular disease, and the results of Dr. Shore-Lesserson's research have been published in high-impact peer-reviewed medical journals, and she also lectures frequently at national and international scientific meetings, and we are so lucky to have her speak to us today. Thank you, and take it away.
Well, thank you very much, Kelly, for that warm introduction. Thank you, Kelly and Dick and Nathaniel, Dr. Usoro. Thank you for this warm invitation. First, I'd like to take a few seconds to just embrace this collaboration between the BMSS and SABM. This has been a long-standing relationship. We are so proud to be here, and I'm so happy to be participating in the SABM session alongside these fabulous talks that we just heard. So it's my honor to be here, and I invite everyone to join us at SABM, our next meeting in September of 2025, which I will share with you in a few moments. So I'll share my screen and begin speaking now about patient blood management and outcomes in cardiac surgery. And this is a topic that's near and dear to my heart. I actually began my interest in blood and blood management years ago when I was studying heparin and protamine and antifibrinolytic agents and antiplatelet drugs. And it wasn't until about 15 years ago that the interests in patient blood management became focused on anemia and anemia management preoperatively. And it's so critical, especially in heart patients, that we manage iron deficiency. So this has now become a true passion of mine that manages to coexist extremely well with bloodless medicine and patient blood management. So I'd like to start by introducing the guidelines that were published a couple of years ago by first author Dr. Peter Tibbe, who is a past president of SABM. These guidelines inform the practice of patient blood management. They span the whole timeline of a cardiac surgical patient's presentation to the medical system. They begin with anemia management. They proceed through cardiac surgery, which is quite complex, especially from a blood management perspective. And they predict outcomes in cardiac surgical patients. So many of the recommendations I will make come from this guideline and stem from evidence-based medicine. We all know the definition of patient blood management. Many of us here today helped to create this definition of a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing, preserving a patient's own blood while promoting patient safety and empowerment. There's a reason why the word patient is mentioned 3 times in this definition, and it is clearly for the benefit of the patient that we proceed to practice patient blood management in cardiac surgery and in all of our medical encounters. So these are the ways in which we help the patient in cardiac surgery. We have anemia management. We have a lot of coagulation defects, and this is part of our coagulation management, a coagulopathy management that we exercise during cardiopulmonary bypass and a cardiac surgical admission. We also have pharmacologic and technological adjuncts to our surgical management. We have algorithms. I like to call them bleeding algorithms because we are trying not to transfuse. So I try not to call them transfusion algorithms. And the interesting part about these are that they now include pharmacologic agents, not blood products. So we are now achieving more closely the management of cardiac surgery patients without blood. And finally, the technological aspects of the cardiopulmonary bypass circuit, which I probably will not get into today in the interest of time. Speaking about anemia management, this is something that I think all of us are very invested in. And the data in cardiac surgery are a little more recent than in the general surgical population. So I'll go over a few of the studies that have led us to understand that anemia management is critical for the management of cardiac surgical patients to have optimal patient blood management strategies and outcomes. This study, published by you and colleagues a number of years ago, was a randomized controlled study in valvular heart patients. They were randomized to receive either IV iron and erythropoietin or placebo. So in these 2 groups, the endpoints they looked at were transfusions up to 4 days and reticulocyte counts and iron levels. In this randomized controlled trial, you can see that there was a small but impressionable impact on hemoglobin levels in the iron and erythropoietin groups versus the control group or the placebo group. And out to postoperative day 7, note that hemoglobin levels were appreciably larger than at baseline or in the control group. Notably, more impressive are the reticulocyte counts, which started to dramatically increase at postoperative day 7. And we know what this means. This means a smoother recovery. This means that when the patient goes home, their retics are still active and they're creating new red blood cells so that they can restore a hemoglobin level that may have been decreased as a result of cardiac surgery. And this is a signal that we're going to see frequently as we look at a little more literature. In this study, also note that patients in the iron and erythropoietin groups received fewer intraoperative red blood cells, fewer red cells on postoperative day 1, 2, and 3 to 4, both in the number of units transfused and in the percentage of patients that received a transfusion. Another study by Donat Spahn in patients that were randomized, and they were stratified by the type of surgery that they encountered. There was anemic and iron deficient patients were included in this randomized controlled trial. And what Dr. Spahn did was he gave a cocktail of medications to treat anemia. So iron, erythropoietin, and folate and B12. And he randomized with a control group. 24 hours before surgery, this cocktail was given, so we don't need a large lead time. And notice that in this EPO or cocktail group, the significant results were evident. Patients received fewer transfusions out to day 7, and the total red blood cell acquisition costs as a result of those transfusions was lower in the treatment group. Now you'll notice that the total acquisition costs were larger, and these are in Swiss francs. The total acquisition costs in the treatment group were larger because of the erythropoietin treatment. And I would put out to you that not all of these patients needed erythropoietin. IV iron itself is often enough of a stimulus, especially in patients with pure iron deficiency. But these patients were not strictly evaluated for what they needed based on their specific anemia. They were all treated similarly, and therefore the acquisition costs, if erythropoietin is involved in all of your treatments, can be quite high. This is a very fascinating study in my mind, because a lot of the reason why we don't treat preoperative anemia in cardiac patients is because we say that we can't wait the week or two that it might take for iron and or erythropoietin to start to take effect. Well, this study administered isomaltose or Monifer intraoperatively, a single dose of 1,000 milligrams. And patients undergoing cardiac surgery were randomized to have either a single dose of iron intraoperatively or a placebo. These were non-anemic patients. So as you can see in the graph on the side, their results show the patients were non-anemic. They dropped their hemoglobin level during surgery, and they recovered to a much greater degree, 12.7 versus 11.6 after surgery. And this is a demonstration that iron therapy is beneficial to many patients, whether they're anemic or not, and whether they're iron deficient or not. The reason for this is that all patients become iron deficient on cardiopulmonary bypass. They may not even be anemic. Even if they aren't anemic, the state of iron deficiency, especially at the level of the myocardium, is exacerbated by cardiopulmonary bypass. And this is something we can't measure, myocardial iron stores. So suffice it to say that in many of these trials, iron treatment has been administered with positive results and very few, if any, adverse reactions. So following that up, a randomized controlled trial in non-anemic patients was conducted and published last year by Friedman and colleagues. And they took patients who were having cardiac surgery without anemia, randomized them to receive either ferric carboxymaltose, 1,000 milligrams, either 1 to 3 days before surgery, or a placebo. Their primary outcome was red blood cell transfusion 4 days post-op. They had other secondary outcomes as well. And note that in this randomized trial, the primary outcome was met. In the iron group, there was a statistically significantly lower number of red blood cells transfused out to 4 days postoperatively. There were also a number of other significant findings. The hemoglobin levels at post-op day 4 at 4 to 6 weeks postoperatively. This is a very impressive result because many times we transfuse patients, or it is said that patients are transfused so that they can feel better. They're weak and they don't want to be sent home in this weakened state. Well, the administration of iron while in the hospital allows that patient to fabricate red blood cells over the ensuing weeks and to create a larger hemoglobin store and level during recovery. And this is critically important for us in the perioperative period. Even in the subgroups that Friedman and colleagues analyzed, all of these specific subgroups had a better reaction and a lower transfusion rate at that postoperative day 4 in the iron group than in the placebo group. So most subgroups benefited statistically significantly. The Euroscore groups, the males, BMI, and other types of subgroups analyzed. So IV iron should be considered, and it's impressive in my mind that this can even be given on the day of surgery. What about the number of units that are administered? We heard earlier this morning, I think Dr. Friedman mentioned, why give 2 when 1 will do? And this has been a great adjunct to patient blood management. If every time we gave a single unit rather than 2 units, as we've been taught, we would significantly reduce transfusions. But is a single unit even indicated when we transfuse? And this is a really fascinating study published by Natalia Girardi and colleagues out of Cornell, where they analyzed the STS, the Society of Thoracic Surgeons database, a gold standard database, a now public reported database of all centers in the United States. And between the years of 2010 and 2019, they were able to acquire 2 million data points of surgical procedures. From the database, they evaluated patients who were transfused and not transfused. So of the patients that were transfused, there were 847,000. They looked into those that were transfused only 1 unit. So that left them with 206,000 patients for comparison. They then propensity matched these single unit transfusion patients to patients that received 0 units. And a careful propensity matching process yielded 206,555 pairs. Incidentally, I can share with you that those patients that received a single unit were more often female, more often small body surface area, and non-white. And they ended up having a higher mortality and morbidity profile, which I will show you on the next slide. So the single unit transfusion patients had a higher mortality, operative mortality, a higher stroke rate, more infection, prolonged ventilation, new hemodialysis, and reoperations. So this is suggestion that transfusion itself, even in a small aliquot, like a single unit, may portend and be a risk factor for adverse outcomes. Now, of course, this was a propensity matched database study. There may have been some confounders that were not recognized in these patient population profiles, but this is really an intriguing discussion point for future practice. Transfusion does predict infectious outcomes. There are numerous data points, numerous studies of retrospective trials and even prospective trials indicating that transfusion is a marker for an increased risk of infection. And our earlier speaker, Dr. Freeman, mentioned this as well in its immune suppression ability. Transfusion can be a risk factor for increased infection. So this study, published by Mike Mazzeffi and colleagues a couple of years ago, demonstrates this very nicely in a large population, Also, the STS database was queried for a 3-year period. And out of roughly 300,000 patients, they analyzed a subset who were transfused red blood cells. And that was 59,000. This was CABG only. So this is actually a really impressive result. In and of itself, only 16% of isolated CABG patients received any transfusion. That's something that centers that transfuse liberally should really aspire to on the way down to no transfusion. So out of these 16% of these CABG patients, they divided the patients by the number of units that they were transfused. And note that most patients received only 1 or 2 units. About 75% of all of these patients that received any transfusion received 1 or 2 units. Also calling into question whether or not that single unit was really indicated and if it
How about there?
conferred any harm.
Hello, can you hear me?
Yes, I hear you.
Oh, I'm so
Okay, sorry, Nathaniel. So in their results, they conducted a mixed effects logistic regression model, taking into account many factors, many preoperative factors, the preoperative risk score, which is shown on the x-axis, and the probability of hospital-acquired anemia, which was a composite of sepsis, pneumonia, and wound infection. And note that as the STS risk score increased, the risk of a hospital-acquired infection also increased. But even more predictive of an increased risk of infection was the number of units that were transfused, with 5 or 4 or more units shown in the orange line being the most predictive of hospital-acquired infection. And similar to this result, we conducted this study at my institution. Dr. Lee and our group looked at our single center STS data. And over a 4-year period out of 2,500 patients, we looked at risk factors for adverse events like prolonged ventilation, infection, renal dysfunction, and others, and mortality. And in careful univariate analyses, we eliminated the factors that were confounders and came out with a multivariate logistic regression that indicated the risk factors for our adverse outcomes. We had final logistic regression models that indicated that red blood cell transfusion volume was an independent predictor for all of these adverse events. And to the effect of, for each additional red blood cell transfused, there was about a 1.5 increased risk for each unit. There was a 1.5 times risk of a prolonged ventilation event. Other risk factors were total platelets transfused, BMI, and time spent on cardiopulmonary bypass. And a similar result for infection, which is what we're talking about. As each individual unit is transfused, the risk of an infectious outcome is increased by a 1.5 times nearly. Similarly, platelets and low temperature were contributory to the infectious outcome composite. So we are striving for zero transfusion. Clearly, every unit that we give increases the risk of either an infectious outcome or a prolonged stay in the intensive care unit. So moving away from anemia management, I'd like to now talk about algorithms and transfusion strategies. Transfusion algorithms, as they are called, are really algorithms that are designed to treat bleeding. So we can call them bleeding algorithms or hemorrhage algorithms. In the interest of time, we certainly cannot go through all the studies. There's thousands. Even if you go through all the randomized controlled trials, there really is not the time. So let me see if I can encapsulate for us what point of care algorithms have done for the management of patients having cardiac surgery. It's a class 1 indication in the STS-SCA guideline from 2021. Goal-directed transfusion algorithms which incorporate point of care testing, such as with viscoelastic testing, are recommended to reduce periprocedural bleeding and transfusion. Note that it says such as with viscoelastic devices. So it doesn't matter where you practice and what you have on board. You really need not have a fancy viscoelastic device. Any sort of testing whose results come back in relatively rapid fashion can be used to organize a management strategy for bleeding. So pictured here are some of the viscoelastic devices, and pictured here are some of the algorithms. But again, there are algorithms that don't really use viscoelastic parameters. There are algorithms that use laboratory parameters. I understand we're all limited by the turnaround time of some of our laboratory values, but anything we can do to rationally look at the coagulation and platelet function is better than an empiric approach to bleeding. So to encapsulate these data for us, I will introduce us to a meta-analysis of all the viscoelastic studies that have been conducted up to 2020. And this study by Mecco and colleagues indicates, as you would expect, that all transfusions are reduced in the viscoelastic testing group: red blood cells, platelets, and plasma. Similarly, outcomes are also measured in bleeding. So if you look at chest tube drainage, you can see that in the viscoelastic testing versus control groups, even chest tube drainage is reduced. And here we are at outcomes. Reoperations, a critically expensive and morbid outcome, is reduced in viscoelastic testing groups because we more appropriately treat the defects, and we can postpone or eliminate reoperations for bleeding. And length of stay has also been positively impacted. Mortality, not statistically significantly, and this is expected. One would not expect a single intervention to have an impact on overall mortality in cardiac surgery. So we've talked about anemia management, the need for anemia analysis and the treatment of iron deficiency, or anemia of inflammation, or a macrocytic anemia in the preoperative period. Patients presenting with higher hemoglobin levels do better and often have easier recovery after cardiac surgery. The preservation of coagulation, one thing we did not mention in the interest of time was antifibrinolytic therapy, a class 1 indication in cardiac surgery to reduce bleeding during the cardiopulmonary bypass period. Algorithms and hemorrhage treatment strategies, as we just discussed, are very important in reducing transfusions and hopefully getting us to our bloodless state, our zero transfusion state. So the results of fewer transfusions and zero transfusion would be fewer adverse outcomes. We see less infection, less prolonged ventilation, and shorter ICU lengths of stay. So in summary, to accomplish bloodless cardiac surgery, we must practice patient blood management. It is a critical component of bloodless medicine. So patient blood management informs the recommendations that are in our guidelines, and it stresses the importance of evidence-based multimodal and multidisciplinary approaches to native red blood cell preservation, coagulation dysfunction management, and protocol modifications to improve outcomes for all of our patients, specifically directed to the cardiac surgical patient. So I would like to thank you for this really incredible honor. SABM has been very honored to be associated and collaborative with the Bloodless Medicine and Surgical Society. We really appreciate our opportunity to be at the BMSS. And I'd like to invite everyone to the SABM meeting next year. It'll take place in Minneapolis, Minnesota from September 18th through 20th. And I look forward to seeing everyone there, everyone who is able to attend. Thank you very much for this opportunity.
Thank you very much, Dr. Bloodless, for your wonderful presentation. We will now move to our Q&A. a question and answer. So we're ready for the Q&A.
And looks like there's one question as of right now. I think this is for Dr. Shore-Lesperson. I know you didn't have time to talk about ultrafiltration use and especially MUF at reducing transfusions and improving outcomes, how important they are.
Yes, thank you for that question. In the interest of time, absolutely, I did not discuss those interventions, but they are critical and they are part of the technological management of cardiopulmonary bypass. So a number of strategies are used. Retrograde autologous priming is a very important technique to minimize the hemodilution by a large volume of crystalloid. We always utilize hemofiltration techniques. These will ensure that we can maintain a higher hemoglobin during cardiopulmonary bypass and after. There are other autologous techniques. For example, autologous normovolemic hemodilution is often practiced. Very important in patients who don't accept autologous transfusions unless they've been in continuity with the circulation. It's important to manage the circuit and the attachments and connections of the circuit to the patient in order to adhere to some bloodless patient wishes. And there are mini circuits. Mini circuits are a valuable resource where we have a prime that could be less than 200 mLs. So we minimally dilute the patient. Now, these cannot all be practiced together. So it's up to a particular program to determine which strategies they are going to use to reduce hemodilution, because practicing all of these together often results in extreme hypovolemia. And so it's really a balance which of the technologic strategies are used. But there are many, and thank you for that question.
Thank you. Let's see, I don't see anything else in the Q&A. I actually had a question for Sarah. I'm Gen X, so I'm kind of older, and I didn't grow up with all the technology that we have now and that the young people are so excellent at using. What do you think is the most effective outreach platform out of all of them that you mentioned? I mean, I see you a lot on LinkedIn, but there's also TikTok and YouTube and all those other platforms. What do you think is the most effective, or is there not one?
Yeah, I would say that LinkedIn, it depends on who the audience you're trying to capture. So LinkedIn is very professional and medical constituents driven. So if you're trying to reach that audience, I would suggest LinkedIn. If you're trying to reach the public, Instagram is more probably effective these days among the younger population. The older population in my age group, like 50s and up, is Facebook. They're still pretty active on Facebook. So it kind of depends on who you're trying to capture.
That totally makes sense. Thank you.
I
Yeah.
think I just a quick question. Are there any social media platforms you would avoid? I mean, we hear a lot of negative talk around TikTok, for example.
TikTok is very entertaining, but I have to say that when we post a reel on TikTok, it gets far more plays. So if you're just focusing on your content being good, there's negative aspects to social media. Like I personally, I'm not a fan of social media, but it's powerful and we need more positive and we need more reliable and accurate information. So we can't just kind of back away from it because it does have a negative aspect. We have to be like that voice for good and expert, reliable information because it's here to stay and it's very, very powerful. And so I have to say, like, if you're a fan of TikTok, put out accurate information. If you're really good at entertaining, that's also great. But we get far more plays, same reel. We can post it on Facebook, LinkedIn, Instagram, and TikTok will outperform it times 10.
Interesting. Cool. Okay, thank you. We have a few more questions. we'll start with, oh, there's several more. All right, so what do you think of the eye tactic study that showed no difference in mortality when using Rotem? I guess that's for Dr. Shore-Lesserson.
Yes. I mentioned this earlier, and I think it's very important that we take patient blood management as a specialty, as a composite of multidisciplinary interventions. And it certainly has to be used in conjunction with other practices. There's a lot of disparity and discrepancy in the use of the viscoelastic tests. Some of the papers don't even show a reduction in transfusion or bleeding, but taken as a whole and looking at the meta-analyses, clearly some sort of organized medicine. This is all it is organized medicine. That's why I don't preach any single test, and I don't preach any single algorithm. Some sort of organized medicine around the approach to bleeding is critical, but it alone is also not going to impact mortality. I don't think any of our interventions in a vacuum will be able to make a difference with regard to mortality. Even antifibrinolytic use, which is really a profoundly impactful intervention that reduces bleeding, taken in an isolation won't make a difference. So practices that have a very well-structured patient blood management program where they pay attention to anemia and they use viscoelastic testing and they have a reduced transfusion incidence, and post-operatively they administer ICU care with attention to the avoidance of blood and normothermia and all of those other things that we know that promote rapid healing. Those will make a difference in mortality, but still only if we study millions of patients. Mortality is a low incidence, so we need an extremely large study to make a difference in mortality in cardiac surgery.
Excellent, thank you.
My own view on viscoelastic testing is I think that it's certainly good technology when it's used appropriately, but I tend to think that it can also be overused and misinterpreted, and that can lead to some of maybe those studies that are not showing transfusion reduction. And sometimes they order it at the expense of the conventional clotting tests, which can be useful as well in evaluating bleeding.
Whoa. Okay, one more very quick question. For cardiac surgery, what is the hemoglobin needed to operate?
Wow, great question. I think there is no answer. If you look at the guideline has different hemoglobin levels. So the hemoglobin level to operate, to me, that means preoperative hemoglobin level. And this is basically the guideline that you or your institution has decided to follow. There's the STS guideline recommendation. There's AABB guidelines to follow. Generally, a patient with cardiac disease is supposed to have a hemoglobin higher than 8. Certain circumstances, it may be 8.5, it may be 7.5. Clearly, during cardiopulmonary bypass, we allow it to go lower than that. And that's also mentioned in the guideline. But the patient's baseline and their disease status and their comorbidities also has a lot to do with what their baseline hemoglobin is. So I don't think there's any level at which if I were a surgeon, I don't think there's any hemoglobin at which I would cancel a case. But if a patient is elective and is clearly undertreated for iron deficiency anemia, there's a good case to be made for waiting a few weeks to operate on that patient, that elective cardiac patient, and allowing them to manufacture more hemoglobin so that they can have a more successful cardiac surgery and recovery.
Thank you for that. All right, well, Dick and I are very grateful for all of our wonderful speakers. So thank you to Sarah, Dr. Shore-Lesserson, Dr. Friedman. Thanks for all the attendees who asked these great questions. And it's now 8:30 a.m. Eastern time in the US, and it's time for us to move on to our next session. So I'm going to welcome our new moderators, Dr. Innocent Okawo and Heather Mingo. And Dick and I are going to sign off. And again, thank you to everyone who attended this session this morning. Have a great weekend.
Thank you. Thank you.
Morning.
And it is 3:30 p.m. or 2:30 p.m. in Lagos, Nigeria. But I'd like to welcome everyone to this special BMSS session. And this session is titled The Art and Science of Bloodless Medicine. And I'll start by being my co-moderator, and she's Heather Mingo. Heather Mingo is the coordinator of Halifax Infirmary Blood Conservation Program, Halifax, Nova Scotia in Canada. I'll also introduce myself. I am Dr. Innocent Okawo. I am the medical director of Safe Hands Medicare Services in Lagos, Nigeria. We are a purpose institution for bloodless medicine and surgery. Okay, Heather.
Thank you, Innocent. As he said, my name is Heather Mingo. I'm a nurse practitioner, and I run the perioperative blood management program at the Halifax Infirmary in Halifax, Nova Scotia, Canada. And I too would like to welcome everyone to the third day of the BMSS 2024 conference. And already we have heard this morning from 3 world leading experts in PBM for the SABM session. The BMSS 2024 special session has been featuring the art of bloodless medicine for the past 2 years. And this time we want to feature the science of bloodless medicine. But before I introduce our speaker, I have some housekeeping rules, just as a reminder for anyone that is joining. All questions should be placed in the Q&A. Minimize your chats during the talk so not to distract other attendees and speakers. And the program, again, is being streamed live on the BMSS YouTube channel in case anyone has difficulty with Zoom. See the YouTube link in the chat or type Bloodless Medicine and Surgery Society in the YouTube search. And finally, please mute your mic during the presentation of our next speaker. I am honored to introduce our next speaker, Elliot Fieldhouse Allen, who will speak to us on the topic AI meets bloodless medicine.
Hi there.
Hi. Elliot Fieldhouse Allen is a dynamic leader and innovator in AI-driven solutions across healthcare, education, and drone surveying industries. With a background in computer science and AI, he founded DataWise AI Limited, an AI consultancy specializing in accessible machine learning tools for SMEs. Under his leadership, DataWise has partnered with Columbia Healthcare Analytics to develop groundbreaking applications of AI in medical diagnostics, focusing on enhancing clinical data processing and predictive analytics. Elliot also serves as the technology director at Eyes in the Sky Limited, where he leads the development of AI drone imagery analysis and environmental monitoring solutions. A key player in applying AI for heritage conservation, environmental health,
and infrastructure assessment. He is at the forefront of combining AI and real-time data collection for impactful results. His current research includes projects in vegetation health and invasive species detection using drone-based multi-spatial imagery, conducting in collaboration with the Swedish partners. In addition to his professional pursuits, Elliot holds a bachelor's with honor in audio engineering from Middlesex University, completed in 2014, with a dissertation focused on cochlear implants. His research explored the limitations of cochlear technology at the time, including the challenges in enjoying music due to restricted frequency bands and the quantization of all sound to approximately 8 to 10 points on the sound spectrum. Elliot, I look forward to hearing your talk today. Thank you for joining us.
Thank you very much. Yes, let me just share my screen. Okay, here we go. Hey, so good morning, afternoon, evening, and night, depending on where you're listening to this lecture from. It's a privilege to address you at the Bloodless Medicine and Surgery Society's annual scientific conference 2024. Today, I will share insights on how artificial intelligence is impacting medical diagnostics in ways that are relevant and practical for bloodless medicine, highlighting both opportunities and challenges. I have no financial disclosures for this presentation, so let's get started. I'm an AI specialist with a background in engineering and have been working in the AI sector for the last 3 years, and I am currently wrapping up a Master of Science in Computer Science with Artificial Intelligence alongside my work as Managing Director of DataWise AI Limited. We are an AI consultancy specializing in helping small to medium enterprises access AI technologies across various sectors. Our partnership with Columbia Healthcare Analytics is founded on a shared vision to leverage AI and machine learning for improving diagnostic and review processes. Together, we've been working on streamlining clinical data processing to reduce administrative burdens and enhance efficiency, most prominently using statistics, machine learning, and artificial intelligence to demonstrate unnecessary blood transfusions in hospitals, allowing them to reduce the amount of blood used on patients unnecessarily, saving the hospitals money and improving the quality of care in patients, moving hospitals towards the goal of bloodless medicine. The learning objectives for today's presentation are: I'm going to demonstrate how AI-powered diagnostic tools can enhance patient outcomes in bloodless medicine by supporting more precise and timely clinical decisions. We're going to explore the application of multilingual large language models in overcoming language barriers for global diagnostic consistency and infection surveillance. And we're going to briefly investigate the ethical and regulatory implications of implementing artificial intelligence in healthcare, with an emphasis on maintaining data security, patient privacy, and transparency in AI-generated insights. The amount of patient data we handle has grown exponentially, making it increasingly challenging to extract actionable insights efficiently. In bloodless medicine, where minimizing blood loss and avoiding unnecessary transfusions are critical, diagnostic precision is paramount. Artificial intelligence offers tools that can assist us in interpreting complex data more effectively, supporting clinical decisions without replacing the essential human element. AI algorithms can aid in interpreting imaging studies to detect signs of internal bleeding, vascular anomalies, or melanomas. AI models can analyze patient data to predict anemia or bleeding risk, allowing for proactive management. And AI can assist in interpreting lab results like coagulation profiles, enhancing diagnostic accuracy and patient monitoring. Here's some examples of imaging segmentation using AI. What imaging segmentation means is that AI can highlight unexpected features of imaging results, as you can see by these 4 examples here. Now we're going to move on to medical large language models, or medical LLMs as they're known. A simple way to understand how large language models, or LLMs, work is they're trained on massive amounts of text, learning patterns in language over time. You can think of it like how we learn a language, by seeing examples and understanding how words and sentences fit together. The model doesn't know things the way a person does, but it's learned to recognize patterns and relationships between words. So when it reads or generates text, it predicts the next words based on these patterns, aiming to make its response logical and relevant. In medicine, this means an LLM can take complex language like patient notes or research papers and interpret it accurately, making it helpful for summarizing, translating, or even generating suggestions based on input from a healthcare professional. Today, we're witnessing a pivotal shift in medical diagnostics, driven by advancements in large language models. These models, initially developed to understand and generate natural language, have evolved into powerful tools capable of processing vast amounts of medical information with remarkable accuracy and sensitivity to context. The LLM I have used and will be showing examples of operations with has been fine-tuned with a dataset of 46,000 internationally recognized clinical practice guidelines from various healthcare-related sources, including hospitals and international organizations, 16.1 million abstracts extracted from closed access PubMed and PubMed Central papers, and full-text articles extracted from 5 million publicly available PubMed and PubMed Central papers. In this example, I used an example of a patient exhibiting thyroid dysfunction symptoms, which is a pretty standard, diagnostic situation. And as you can see, here are its outputs. This medical LLM has been instructed to provide a couple of options for diagnosis in order to prevent getting stuck down one specific diagnostic pathway. But as you can see, it has identified 2 potential options, one of which being thyroid dysfunction, and it has suggested various tests that can be used to sort of assess whether or not it is a thyroid issue or it is Addison's in this suggestion here. LLMs can facilitate telehealth by breaking down language barriers, enabling doctors and patients who speak different languages to communicate effectively. This capability also allows doctors worldwide to collaborate on cases in real time, providing remote areas with access to global expertise regardless of the language that they are practicing in. So I put the same input as before, a thyroid dysfunction, but I used Pidgin English as the input language, asking it to output in British English to demonstrate an understanding of both languages. Now, it's unlikely that doctors in Nigeria would write patient notes in Pidgin English. However, using AI transcription and diarization, practitioners can communicate with patients in accessible languages, record the discussion, and have patient notes automatically composed in standardized clinical English. I then did the exact same thing in French. And as you can see, it can understand the French and output English. And I also did the same with Arabic. One thing to note is that in all of these examples, I've input one language and got it to output in English, but you can actually put English in and get Arabic out. You could put English in and get French out. You could put French in and get French out. So it's really, really, it's multimodal in language terms, essentially. Multilingual LLMs support real-time infection surveillance by tracking data from various regions, providing consistency in infection trend analysis. LLMs are able to offer treatment recommendations aligned with local guidelines, helping drive global treatment standardization and improve patient outcomes. But also, what this means is if a practitioner is practicing medicine in another language, they don't need to translate what they're doing into a reportable language. This can automatically happen. And not only that, automation can automatically report the statistics as they come in. By standardizing medical diagnostics, multilingual LLMs can significantly improve access to and healthcare equity, particularly in underserved regions. DataWise and Columbia Healthcare are positioning themselves as leaders in this field, enabling equitable, standardized, and real-time medical diagnostics worldwide. While artificial intelligence holds significant promise, it's important to recognize its limitations. AI systems may generate false positives or false negatives, leading to unnecessary tests. AI depends on data accuracy, and poor data can mislead the outputs. And compatibility issues can challenge artificial intelligence integration into existing clinical workflows. And of course, it's important to ensure data privacy and obtaining consent when implementing artificial intelligence solutions. Several studies indicate that artificial intelligence improves diagnostic accuracy in imaging and predictive analytics. AI-assisted imaging helps early detection of many different conditions, and the sooner a problem is identified, the more carefully that patient can be managed, resulting in a lower likelihood of blood transfusions. However, it's important to approach these findings with balance, understanding AI as a tool to assist, not replace clinical judgment. At DataWise AI, we have a creed which we live by, which is AI generated, human verified. As we, both the industry as well as the partnership of Columbia Healthcare and DataWise, continue to develop our AI capabilities, reducing false positives is a priority. By refining these models to improve accuracy and reliability, we will be increasing the utility and effectiveness of artificial intelligence in clinical settings. This directly benefits patient outcomes by ensuring clinicians receive accurate and actionable insights. Transparency is key in healthcare. Explainable AI enables clinicians to understand the rationale behind artificial intelligence-driven recommendations, fostering greater trust in these systems. This transparency not only helps in decision-making, but also supports compliance with regulatory standards and ethical practices in artificial intelligence usage. AI offers exciting possibilities for supporting tailored patient-specific strategies, moving healthcare away from a one-size-fits-all, transfuse-everybody approach. By leveraging patient data and predictive analytics, artificial intelligence has the potential to help clinicians design personalized care plans, ultimately improving patient engagement and outcomes. This approach showcases how AI can enhance the precision and relevance of medical interventions, leading to more effective and patient-centered care. And collaboration with medical professionals, such as the people watching the presentation today, is vital. By actively engaging with each other and, amongst all the stakeholders in the healthcare sector, we will ensure AI tools are practical, clinically relevant, and aligned with real-world needs. This partnership-driven approach will also facilitate continuous feedback, allowing us to iteratively enhance solutions to meet the evolving demands of the healthcare industry. Compliance with regulatory standards is necessary when integrating AI into medical diagnostics, requiring rigorous testing and approval processes. Respecting patient autonomy and privacy is vital. Ensuring robust data security measures are not only legal requirements, but essential for maintaining patient trust. In summary, AI has the potential to be a valuable support tool in medical diagnostics, offering benefits particularly relevant to bloodless medicine. By addressing challenges, we can integrate AI in a way that enhances practice without overburdening practitioners. Collaboration between AI specialists and medical professionals is essential to ensure effective technology development and implementation. Thank you for your attention. I'd welcome any questions you may have and would appreciate hearing your insights on how AI can be integrated into your practices in bloodless medicine. The references for my presentation can be found on the PDF version, which will be available for download.
Thank you, Elliot, for your time, effort, and expertise in this area. Your presentation, wow, has left us a lasting impression. And, I found your insights informative and very inspiring. So I want to now open it up for question and answer. And I'm just going to look in the chat box to see if there's some questions. So the first question was, can you address vascular tone and volume loading as a knee-jerk response in surgery?
I think those are questions from the previous presentation.
Oh, I apologize.
That's okay. No problem. But yeah, I'm open to any other questions about artificial intelligence you might have.
Anyone from the listening online have a question for Elliot?
No, well, that's okay. If anyone does have any other questions, they can feel free to, send me an email at elliot@datawise.ai.
Okay.
And thank you for your time, and thank you for listening.
And I'll ask the group here to make sure that they send your email out. So if anybody wants to contact you later.
Perfect. Thank you so much.
Great. Thanks.
Bye.
Bye-bye. So I think, Innocence, you're up.
Yeah. We saved some time, but we're about 20 minutes early.
So if there were some questions that were not answered, perhaps the members of the panel can try to answer them before we move on.
Okay. Okay. Well, there were no questions actually.
No.
Yeah. So, well, I'd like to thank. Well, the speaker is gone.
I'm sorry. The question on albumin/total protein level, was it answered?
It wasn't for him.
I know. I mean, there are other panelists that
Okay, so
might wish to address.
yes, please. It was actually directed to the other panelists, and if they're still with us.
And I think Michael Rora might want to make a comment if he will raise his hand. Schneider, are you able to?
Yeah, his hand is up, and his microphone is on.
He's enabled. Okay.
Okay, just a question, and I may have misunderstood in that outstanding talk by Dr. Linda Short-Lesserman. I thought I heard the phrase constant contact as far as a witness requirement for A&H or cell salvage. Just to set the correct is for witness patients, they would decide for themselves how their blood would be handled in the course of a procedure, a medical test, or a current therapy. So even if some of the blood is diverted outside the body and the flow might be interrupted for a time, it would still be up to their conscience whether they would allow this to view that blood as still part of them and accept this procedure. So great program. Just want to clarify that it doesn't, for witnesses, it doesn't require constant contact. Thank you very much.
Okay, thank you very much.
So I think he was addressing the recurring question of whether a circuit or bypass circuit has to be continuous for JW patients, and he's saying it doesn't have to be.
Yeah.
And I believe he's in the HLC.
All right, I hope that's what as it stands, different persons understand, decide on what they want their blood, what is allowed, what you want to use the blood for. So some persons may allow you to do ANH. What they would not allow you to do is pre-donated blood. That's preoperative autologous donation. That's PAD. But as for acute normovolemic hemodilution or acute hemodilution, a lot of patients would allow you to do that as long as it's in continuity with their circulation. Okay, so we would, if everyone is here, we are about to start the annual general meeting. So first of all, I'd like to thank all attendees, as well as my co-moderator. It was indeed interesting to watch you both speak. And then our speaker, obviously, he has lots of things to do. So he quickly just delivered his lecture, and we had. So today is our annual general meeting, and I hope my president is on cue to take over for the AGM. Nat?
Yes, I'm with you.
Okay.
I just wanted, let me turn off an alarm that is making noise behind me.
All right, that's fine.
So I want to say a big thank you to all the speakers, the moderators, panelists, and everyone who has been part of this meeting, the BMSS 2024 annual meeting. Thank you so much to special thanks to the affiliate organizations, the MyPBM, which had that society, Malaysian Society for Patient Blood Management, that had a session yesterday. And today, what a wonderful session from the Society for the Advancement of Blood Management. Many of us here belong to both societies, including myself. And there are members of those societies who are also in BMSS, because we're all working together to improve clinical outcomes for our patients by avoiding blood transfusion. There are wonderful lessons that we have learned at this meeting, and we want to take them home, make use of them for our patients. And even we mustn't forget the lessons from the past meetings too. I think it is quite clear to any medical scientist around the world that avoidance of blood transfusion leads to improved outcomes. It's very clear that blood transfusion is an independent risk factor. There's no paper that questions that. It's an independent risk factor for increased morbidity, increased mortality, and in all categories of patients. Recently, a paper from the Lancet caused an uproar showing that patients in hemorrhagic shock who are transfused, they were no better off than those who received normal saline. Many people were shocked by that, no pun intended. But actually, many years ago, there was already a paper that went beyond that to show that patients who receive blood transfusion in shock, that the outcomes are always worse. The Lancet paper suggested equivalent outcome to normal saline. But the previous paper, so many years ago, actually said worse outcomes. That was a paper from the US. The only difference between the two papers is that the one from the Lancet in 2021, I think, was a randomized control study. So that actually brings to the front burner the question of efficacy of blood transfusion. Because if it is not really accomplishing anything, and again, one of us in BMSS and SABM has authored a paper recently to show that transfused patients have a lower, they actually go into hypoxia. And that's not what we tell our patients. We tell our patients that when they get transfused, it's going to improve the tissue oxygenation. So none of this is supported by science. What science is actually telling us is that blood transfusion causes hypoxia, delays wound healing. It leads to all manners of complications, longer hospital stay, tumor recurrence, and so many other problems. Surprisingly, there is not, to my knowledge, a single paper that has come out to refute these things, to show that these patients, this group of patients, when they are transfused, they're actually better off. Some people say we should have randomized control trials, but there are no randomized control trials showing that blood transfusion works. And actually, the burden of proof is on the therapy to show that it works, not to disprove. So even cohort studies, we don't even have cohort studies that show that blood transfusion leads to better outcomes. And that is why in the Bloodless Medicine and Surgery Society, we focus on how to avoid blood transfusion in every subspecialty, how to totally avoid it. We listen to our wonderful speakers teaching us how we can avoid blood transfusion, not how to transfuse less. How do you do a cardiac transplant without blood transfusion? That's what we want to know. And that's what we've been hearing in our meetings. How do you do liver transplant without transfusion? How do you do various challenging surgeries, obstetric surgeries, cesarean sections, and so without transfusing a drop of blood. As the Sabon president pointed out, that slogan, why give two if you can give one? We've actually raised the stakes. Why give any when you can give zero? And the science is supporting it. The paper she pointed out from the Society of Thoracic Surgeons shows that those who receive zero blood transfusion actually do better. And who are those? These are patients that receive bloodless care. And I think the effort is in making these things, making the world aware of these things is paying off. Even the patient blood management is evidence that the effort is paying off, because patient blood management is an attempt to bring the benefits of bloodless medicine and surgery to a wider population beyond patients who decline blood transfusion. By the way, that's the language we use here. We talk of declining. We learned that from one of our great gurus, Dr. Arya Shanda. He talks of patients who decline blood transfusion. We don't say refuse, because it's not candy. We're not offering them some candy that they refuse. We're offering them dangerous biological therapy with no evidence of benefit scientifically, and they have every right to decline. And lo and behold, the outcomes are better for these individuals. And so to bring the benefits of this to others, that's how patient blood management came about. Because medicine, one of the key ethics of medicine is justice. The other ones, autonomy, yes, to respect autonomy, that's bloodless medicine. Beneficence, that's bloodless medicine. Non-maleficence, that's bloodless medicine. And justice, well, the name is PBM, so as to not make it look like it's for a limited group of people. But we know that it came from all these three pillars of PBM came from bloodless medicine, came from the work of Dr. Denton Cooley. And in BMSS, we actually divided into 4 pillars, because the anesthesiologists among us have taught us the importance of tissue oxygenation, and blood transfusion causes hypoxia. So we set it out as a pillar on its own, that we have to improve tissue oxygenation. And that's how we came upon the 4 pillars. So on the whole, it's been a great meeting, and this is not, I'm not giving the vote of thanks, I'm just appreciating all who have spoken and who have participated in the meeting, and encouraging all of us to take home those important messages. So let me see if I can share my slide on the agenda for the meeting. My computer is being a slow coach this morning. Yep. Gradually, it has woken up. So I would like to welcome everyone to the annual general meeting of the Bloodless Medicine and Surgery Society. We have just benefited from the scientific meeting, and this time is the annual general meeting. And please, everyone here is welcome to stay, both members and non-members. So in the agenda, we have welcome, review of BMSS 2023, updates on BMSS 2024 award, BMSS 2025, and handing over to the new BMSS president. So please stay with us. We're not going to take time. We'll make sure that we keep strictly to time. So I think the first part, the welcome is already done. So we'll go to the second part, and I'm going to stop the share. So this second part about the review of last year's annual meeting. It was to be done by the conference chair for that year, but unfortunately, she is unavoidably absent. So we can all chip in here and say our impression of that meeting. Let me see if I have the program for that meeting here. Okay, so this was the annual meeting of 2023. It seems that I'm not with the program right now, but it was on compassion in bloodless care. So let me stop the share, and those who were present at that meeting, you're free, please, to make some comments on that meeting. Maybe we'll start with Sandy, Sandra Mann, who is the secretary of Bloodless Medicine and Surgery Society.
Thank you, Dr. Osoro. You know, just taking all of this in and just having the conference that we did, I'm not sure exactly how you want me to present as far as thoughts, but I can tell you that every conference we have done has been so inspiring. You wonder how we're going to top that next year, except to say that medicine keeps moving forward. And the things we bring to the table just help make PBM better. And this year, I'd like to say that introducing AI and informatics to the platform really brought in some new insights, you know, because it is a world that is not going away, and is something that we all do need to be informed of because it affects all of us globally.
Yeah, thank you so much, Sandy. I think I've been able to pull up the program so I can actually remind us a little of how it went.
Thank you. At this point, that might be a little helpful.
Yes. Compassion at the heart of bloodless medicine. That was it. Can you see it?
If you can just run.
Sandy, is my screen showing? Is it showing over there?
Yes.
Okay, so, right. So, Dr. Jamila Sata was our conference chair. And I think it's almost getting to midnight where she is now, and she's unable to join us today. So that was it. The keynote address was by Dr. Shanda, and compassion at the heart of bloodless medicine. And then our current conference chair, Dr. Waters, gave the 5th BMSS Arishanda lecture on bloodless care with compassionate obstetrics anesthesiology. And our matriarch of bloodless care, Sherry, gave the talk on compassion and nursing in bloodless medicine.
Yes, and I
By the
recall.
way, Sherry
Dr.
was to feature at this conference. Please say that again.
Oh, no, I'm so sorry. No, I was going to say, as I recall, last year,
Okay.
we had such a strong support from SABM, as we do every year. But really, some of the, having Dr. Arya Shander, Dr. Waters, who was not able to be with us on this conference, and Sherry, just such a strong support of foundations that have been laid over the decades with SABM, and they were really ground level when you think about it. All of us really are and have supported for decades, and have been there whether we have been in the spotlight or not. But for last year, I remember that when Dr. Waters opened up his presentation, he really looked lost for how to tie in compassion to the conference. And he actually opened it up by saying, I believe, that he was like, I don't know how much, compassion is going to tie into my presentation, because I'm not sure how to tie it in. And then he went on to give this very compassionate presentation because the passion oozes from us. We have it in us, we live it. This is our passion. And so you cannot help. Every presentation we all give, you can feel it. You feel the inspiration. Definitely, we all live it, and we're whole-souled in it.
Thank you, Sandy. That's correct. So we had oral abstracts, and on Thursday we had the session on medical ethics and medical legal issues in bloodless medicine, which was very enlightening. One of my teachers, Professor Domagba, gave the talk on compassion, an essential quality for ethical surgical practice. So he took us through ethics in surgery and in medicine. And we had Dr. Kaufman speaking on compassion and ethics in bloodless medicine and surgery programs. And a lawyer who is a member of BMSS gave the talk on medical legal issues in bloodless medicine and surgery. And there was a symposium on bloodless surgery techniques where Dr. Shaw Lesserson gave the keynote address, just like today. Johnson Arbor and our president-elect, Dr. Christopher, well, he shouldn't be called Dr. Christopher Simotoe, because he's a fellow of the Royal College of Surgeons of Ireland and Edinburgh. They answer Mr. When you climb up to that level, you drop the doctor and answer Mr. Mr. Christopher Simotoe gave us a talk on bloodless surgery techniques in a low resource setting. And we had the SABM session in which the SABM president at the time, Dr. Burns, spoke on plasma transfusions, showing us that it doesn't really work. And Dr. Bloomberg told us also that platelet transfusions don't really work. We study for these things, we take examinations in them, and we say all kinds of things, but the people that work in the area, if you talk to any of them, the people that work with plasma, that work with platelets, all of them will tell you the same thing, that there is no evidence of efficacy or benefits. And they would even explain it with respect to plasma. They will talk about the INR. That's what is the INR of the stored plasma? And lo and behold, it is actually lower than that of the patient. So then calls and the art of bloodless medicine was presented by a renowned professor of surgery from the UK, Dr. Nadi Hakim, who has been a past president of the International College of Surgeons. And he's also a sculptor, musician, and he's into a lot of arts. And I think he took us through that. So
Dr. Thorough.
yeah. Yes, Sandy, you were moderating then. You want to say something about it?
No, I just wanted to say that I found it kind of funny. A lot of our talent when we present as the art in the science has come from the UK as of today as well. I did want to say that Dr. Hakim gave us such an impressive slideshow as well that really opened up our eyes to what is going on with behind the scenes of a lot of our presenters and leaders in the field, so that it really brings in the heart of the person themselves. And so I'm glad we're doing this with the art of our sciences as well. Sorry, I did not mean to.
Right. No, that's great. Thank you so much for that. So we had more than 1,000 registered. I think it was nearly 1,100 that registered for this meeting. And at any one time, there was about 300 people on. Actually, the numbers we see can be misleading. Zoom gives a more accurate representation because some people are using multiple devices, and they share the link, or they share the link. I mean, somebody could have 3-4 devices, and maybe they're in a group in a hospital setting, and they're giving one device to people, like 4 people who are watching, and the other device, the other person is watching with 3-4 people. So the numbers are actually more. But on the whole, it was quite an exciting meeting, very successful, just like the meeting of today. So please, before we move on, anybody else want to say something about last year's meeting? Chris, you want to say something?
I think last year's meeting it really touched what is on our heart as the medical professionals if we are providing bloodless medicine. If you have that compassion for that client you're treating with, and you really want to provide that quality treatment which is respectful, and really when you know the effects of blood transfusion, you put that aside because you're compassionate. You want the patient to recover quite well without any complications. So I think it really touched the heart of those providing that care.
Absolutely. So if anybody else wants to say something, you can put up your hand. But otherwise, we'll return to the agenda. Let me see if I can find it. I think this was it. Right. So now we go to the next item, which is updates on Bloodless Medicine and Surgery Society. And we'll just want to remind ourselves that the Bloodless Medicine and Surgery Society is an international multidisciplinary society of experts and stakeholders in blood transfusion avoidance. It was founded in 2015, and that was when we had our first annual scientific meeting. Our mission is to bring home the benefits of current scientific evidence in blood transfusion avoidance to patients and clinicians all over the world by encouraging the teaching and practice of bloodless medicine and surgery, as well as research and dissemination of scientific information on bloodless medicine and surgery. Of course, today we have learned that podcasts are a potent medium for disseminating this information, and Sarah has thrown out a challenge that who's going to be doing it in bloodless medicine and surgery. I think that challenge it can go to anyone, but the younger ones should please, those who are on Instagram and TikTok and all that, should please look into how they can do it so that we don't have older ones coming to disgrace the younger ones who are said to be more knowledgeable. Anyway, so we want to diversify, think of other ways we can reach people beyond just holding the scientific conference as we are now. And I think we'll definitely look into the area of podcasts. So our vision is to establish bloodless care as a global standard of care for ethical and evidence-based practice of medicine, rather than an alternative. Already, PBM is generally considered as a global standard of care. So in a way, that helps, that will help to establish bloodless care as a global standard of care, because we've heard that PBM with giving just one unit of blood still leads to problems, still leads to adverse outcomes, no benefits. Some people ask, where did this idea come from that we should always give 2 units of blood instead of 1? I can tell you, in the West African College of Surgeons, that's what we were taught, that give 2 units of blood, because if you give 1 unit, it means the patient did not need it. And the proponents can argue it well that, look, it's like a drop in the ocean. Give a unit of blood for what? What are you really improving? Nothing. You're not improving oxygen, tissue oxygenation. You're not really improving the hemoglobin and all that. So if you must eat a frog, eat a fat one. That was the teaching. But the movement came to reducing to 1 unit of blood. And it was found that even that 1 unit of blood still causes problems. So the push now, we have to raise the stakes. We push for 0. And that lands us squarely in bloodless medicine and surgery as the standard of care, not an alternative. So we currently have more than 200 multidisciplinary membership from 5 continents. I don't think we have anybody from Australia at the moment. The people from Australia are just guests. Or does anybody, have I missed something? Anyway, I'm not very sure of this because we are continually receiving a membership application. So it may be we've had someone from Australia, but this, as of last year, we didn't have. And of course, we're still looking for membership from Antarctica. So if you know anybody who lives there, then we'll be happy to have membership. So, so we have organizational affiliates. First, with Society for Advancement of Blood Management. And then we added the Malaysian Society of Patient Blood Management. And you can see that my PBM had a session in our meeting this year because they became affiliates of ours just before the annual meeting last year. That's why they didn't have a session. So every year we hope to provide a session for these wonderful speakers from my PBM. They have also been inviting us to their meetings. I was
Oh, it sounds like we might have lost Dr. Soro.
Is ready to pair.
If that's right, I wonder, Dr. Simatu, are you able to continue the agenda for the meeting? Does anybody have access to be able to do that while we wait for Nathaniel to log back on?
I don't have any access to the agenda. I think he has all the details.
Oh, he's returned. Okay.
My laptop got frozen. Right now, I am using the alternative. My task return. The laptop is trying to return. So I was saying that we are relating more and more with other societies and organizations. This year, we were invited to give a talk in the Wefan College that requested our endorsement for their PBM certificate course, which held last month. It was quite a successful course, and a number of the speakers there were able to share this important message about bloodless care with them. And I think it was very well received. My own topic was bloodless surgery in the era of patient blood management, a perfect complement. So we trace the origin of bloodless medicine and surgery and PBM and how they're intertwined. We also, during the Bloodless Medicine and Surgery Week this year, we were able to bring on board the Ibero-American Society of PBM. That is the Spanish-speaking Society of PBM. We're still working on extending a hand of fellowship to them to see if they could, have an official organizational affiliation with us. Okay. Please just give me a minute. Let me see if I can get my laptop connection back because I need to share some slides. Let me see. Okay, I think it's come back. Yeah, because the next item is a very important item, and it's not nice not to screen it. That is the BMSS 2024 award. This is the next item on the program. It's only that technology it proves disappointing when you need it most sometimes. Schneider, let me see if I can send you the slides to share first.
Okay. Have you sent it, Dr. Yusar?
Yeah, I'm trying to do that. And my email is acting up too. Let me use another device. Schneider, you had some nice music that you wanted to play for us, and you didn't have the opportunity.
Would you like me to also put up the welcome page as well, just to have that?
Yeah, if it requires that, okay. But it's the music that we're interested in, because you wanted to play it and we didn't give you the opportunity.
Okay. Can you hear it?
Sorry, afraid not.
Okay.
Okay, I'm sorry, it went, we're not sharing anymore. The next item was the BMSS Award of Excellence for 2024. And I guess you can see me. Can you see me, Becky?
Pardon me, what did you ask?
We can see you.
Okay,
Yeah, we
okay,
can see.
good.
Yeah.
I always find out if you can. Okay. So I'm saying that we're not going to rely on technology anymore. I don't seem to be able to share. When I try to share it goes off. So I'll just read from my laptop. So the BMSS Award of Excellence was instituted in 2015, and the award is for an individual or an organization with a track record of outstanding contributions to the science and practice of bloodless medicine and surgery. The awardee must have a track record of outstanding contributions to the science and practice of bloodless medicine and surgery in any or all of the following areas: academic, clinical, and advocacy. So our awardee for this year is a consultant general surgeon from Zambia, working in Luanshya Mine Hospital, Luanshya, Zambia. He has been providing bloodless medicine and surgery service since 1989, and he has been a full member of the Bloodless Medicine and Surgery Society since 2021. He was the conference chair for our annual meeting in 2022, and he's a member of the BMSS 2024 Planning Committee. That is the planning committee for this year. And he is currently the president-elect of the Bloodless Medicine and Surgery Society. He's very passionate about continuous learning, medical advancement, and bloodless care. And I can tell you, he has never missed a single scientific meeting or committee meeting in BMSS since he joined. He has delivered insightful talks at BMSS annual meeting and the Bloodless Medicine and Surgery Week webinars. And in fact, at this very meeting, he delivered the 6th BMSS Ariashanda lecture. So I'm sure you can imagine who I am talking about. And that is Mr. Christopher Simutoe. Schneider, please, could you highlight him? Okay, I guess you've done that because I'm using my tablet, I cannot see. If you can see, this is the award plaque for Dr. Simutoe, and it clearly says here, Bloodless Medicine and Surgery Society Award of Excellence, presented to Christopher Simutoe, Fellow of Royal College of Surgeons of Ireland and Edinburgh, for his excellent contributions to the science and practice of bloodless medicine and surgery on this 8th day of November 2024. So that is the award plaque. And congratulations to Dr. Christopher Simutoe for being the awardee of BMSS 2024. And I think we can give Mr. Simutoe an opportunity to say something, please.
Thank you very much, Nathaniel. I was not expecting this. Thank you very much. I think about this passion of bloodless medicine and surgery. I think the passion really dates back a long time ago. It was 1976 when I lost an uncle, when the doctors, he had an intestinal obstruction, and those were in Osaka. They felt they refused to operate because they didn't want to get blood transfusion. I was at secondary school then, and I committed myself that I think I should train to become a doctor, to become a surgeon, and to be able to provide that bloodless operations. And I think it's like a dream come true, really, after so many years. At least I'm able to practice this. Thank you very much for this honor.
Thank you, Chris. Dream of setting up the blood was given birth to in Zambia. And we were guests of Chris and others to speak to the Zambia Medical Association on patient blood management. And that was 2011. That was when we put our heads together and decided that we should start the Bloodless Medicine and Surgery Society. And we are very, very happy that today Chris is receiving this award, and moreover, he is our president-elect. So, like I said, unfortunately, I'm not able to get my laptop back. And but this next item on our agenda, let me see. It was a BMSS 2025. And again, unfortunately, I'm not able to share my screen, but the BMSS 2025 is going to be November 5th to 7th, 5 to 7, Wednesday to Friday. And the theme is going to be technology and bloodless medicine. So I think we've started off on a sound footing with the last talk at this meeting on AI and bloodless medicine. So we are ready to move on to talk about other technologies and bloodless medicine at the next meeting. But that next meeting is going to be presided over by a new BMSS president. And again, technology is wreaking havoc right now. We are not able to show things on our laptop, but the new BMSS president, we had introduced him as the president-elect last year. We were able to screen, his background and his accomplishments and so on. And incidentally, he also is the awardee for BMSS 2024. That is Mr. Christopher Simutoe. Please, Chris, forgive us when we call you doctor, because we are so used to saying doctor. And in fact, you were a doctor before you became Mr. And so we might still be calling you doctor sometimes. And so technology may not allow me to hand over the way I would have loved to, but please be assured that at this time, I am once again introducing to you the new BMSS president. And Schneider, if you can add him to the screen, so you can see he is Dr. Simutoe is our new BMSS president, and we are all going to continue working with him to move BMSS to greater heights. All myself included and all the members of the board of trustees and the executive committee, we are solidly behind Mr. Christopher Simutoe. And so at this point, I will formally hand over to him. I am not, he is going to be in charge of the meeting from this point forward. So he will take any of AOB, what we call AOB. I don't know whether that's the language in other parts of the world, but the AOB is any other business in any meeting. So he will handle the AOB and also will call on Becky to give the final conclusion on behalf of our conference chair. And I want to seize this opportunity to thank everyone, because it would have been impossible to handle and to be at the head of a society like the Bloodless Medicine and Surgery Society, which started locally but became international. It would have been impossible for me if it were not for each and every single one of you, including the attendees in the audience. If you were not here, I mean, our meetings would amount to nothing. So I want to thank everyone here, the members of the board, the President-elect, the Secretary, Sandy, our admin officer, UD, and many others who have been working with me. And of course, the members of the Board of Trustees, including Daniela, Abigail, and others. Please, I want to give my heartfelt thanks to everyone. Please don't mind if I didn't mention you by name. And of course, I already thanked our affiliate organizations who have been solidly behind me throughout. The SABM, that was where I started learning about bloodless care. It was in SABM and my PBM and others. So thank you so very much. And over to you, Chris.
Thank you very, very much, Nathaniel. I'm very, very grateful to the Board of Trustees for Bloodless Medicine and Surgery Society for allowing me to serve in this position. All the members of the society, especially those in the executive and the secretariat, have worked extremely very well to bring the society to its international standards. I'm sure with all the support as a team, the society will continue to showcase the evidence that the bloodless medicine and surgery is the ultimate quality medical practice. The other partners who have been supporting BMS very well are the ones Nathaniel mentioned, the Society for the Advancement of Patient Blood Management and the Malaysian Society for Patient Blood Management. And your support and encouragement has been overwhelming, and we urge you to continue supporting Bloodless Medicine and Surgery Society. Your commitment is evident by accepting to serve in the organizing committee, meeting monthly, despite the wide time ranges. I heard a few days ago, whereby with Becky in Canada, it was 04 in the morning. Some people were still asleep. While Mandy and Jamila in Malaysia, it was 8 p.m. It shows the commitment that you have. We truly thank you for the support. Our outgoing president, Nathaniel Osoro, he's really been the driving force of the Bloodless Medicine and Surgery Society. We thank you very much, and we thank you for the exceptional leadership and guidance. I'm sure you always be available to offer guidance to us. We all look forward for meetings next year. That will be May and November. I thank you once more for allowing me to work with you all. Thank you. For any other business, unless if there is any other business, anyone wants to comment before I call upon Becky to close. Becky, you can close the meeting. And any other business?
Thank you very much. So I want to give a number of thank yous, and many of these will copy some of what Dr. Osoro just shared. And so we had an excellent few days, and we're really privileged to be part of this excellent group, and everything that everyone was able to contribute in terms of education, learning, input, comments, suggestions, etc. So to start out my thank you, I would like to acknowledge the organizing committee who put a lot of time, a lot of hours, numerous meetings into putting together this program for you. So I hope I haven't missed anybody from this list. If I have, we'll mention them afterwards as well. But as you can see by the number of people here, it was an enormous team that worked together to produce what you've just experienced for the past few days. Next, I want to say a big thank you to our organizing partners. Let's see if I can make my my slides advance. I don't think that they want to cooperate. Are you all able to see my thank you screen? Is that showing up?
Yes. Yes,
it is. Okay, sorry. I think my problem is that my slides don't want to advance on me right now. But see if I can figure out why that might be. I think it's
technology has been very rebellious today.
Absolutely. So maybe I'll just say this verbally then. So I really want to give a significant thank you to our partners between the Malaysian Society for PBM and SABM, the ability for the Bloodless Medicine and Surgery Society to team up with all of you to produce this meeting is really appreciated. There's a lot of expertise between all of these organizations, a lot of supporters of all these organizations, and it's wonderful to be able to have this collaboration to produce the content that we do here. Next, a significant thank you as well to all of our presenters, knowing how much work that they did to put together their presentations, the time it took to come and join in and share this with us. We thank everyone for that. All of the moderators and panelists, the volunteers behind the scenes who were able to share the Q&A, to help give the housekeeping notes and get us all started every day. Thank you for your time. And for all of the attendees, likewise, for you being here. Our ask of you is to go home, spread the news, spread the practice of bloodless medicine and surgery and patient blood management so that all patients can be so benefited by this field of medicine. And finally, as Dr. Osoro shared, please save the date for next year. Around this time, November 5th to 7th, 2025, we certainly hope you'll join us. So on behalf of Dr. Jonathan Waters, the conference chair, our Bloodless Medicine and Surgery Society executive group, and everyone here, thank you for attending this meeting. And we can officially call this program closed.
Thank you, everyone. And bye-bye. See you next year.
Thank you. Goodbye.
Thanks,
Thank you,
everyone. It was a
everyone.
wonderful conference. Thank you
Bye-bye.
so much, Nathaniel and Becky.
Congratulations
And
to our
Mr.
new president.
Yes,
And
Mr.
thank you, our past president,
Simcoe.
for your hard work.
Becky, you've been wonderful. Thank you.
Thank you all.
All of you.
Congratulations.
Amy Schneider.
Schneider.
For being here for us. Wonderful
Thank you.
work.
Good job.
Dr. Yakubu.
Chris, congratulations again.
Yes.
Okay.
We'll see y'all next year.
Bye-bye.
I don't think we got a picture, did we?
Oh, I guess we did.
I was gonna wait for everybody to stop talking to say that, but we didn't have a picture.
Do anything. But if there's still anyone there.
Yes. I guess if everybody has a camera on that's able to do so.
So you can put everyone in gallery view. Okay. Schneider.
Yes. Everyone is in gallery view.
Then you can do the screen grab.
Everyone is in gallery view. So I guess this is everybody that can turn on their cameras, but I think Dr. Yusaro just logged off. He's coming back.
I wonder if he's trying to come back.
Oh, there he goes. Okay. All right. So I'm going to take the picture now. Let's see, you ready? Smile. I have it. I can take one more just in case. Okay. And just smile one more time. Wait 1 second. Oh, wait 1 second. A smile, get ready. Okay. There you go. We're good. Been saved.
Okay.
So Schneider, the host, you can take it off.
Yep.
Thank
Okay.
you.